Hello, friends. I'll be talking on this journal article that came in intensive care medicine in 2021 called the controlling study. So it's a good study in endocrine domain. So looking at individualized versus conventional glucose control in critically ill patients. It's a controlling randomized control trial. So as we know, friends, for all intensive care listeners, the glycemic control for us, which is considered as a quality benchmark, is to maintain blood sugar level less than 180 for all our intensive care patients. So this has been debated, and this study was to see whether targeting the glycemic control to the pre-admission levels as compared to having this reference of less than 180 would make a difference. So it is akin to maintaining MAP of 65 versus maintaining pre-morbid mean arterial pressure or pre-morbid blood pressure. So it is very similar to that. So this is a trial which is conducted in a very robust way. So they have put in a lot of efforts. I think this was done by the French group to do this study. So we'll just take you through this trial, how this was conducted. So the hypothesis they had was targeting pre-admission glycemia, which means the pre-admission glycemia was derived from their HbA1c levels. So they checked the HbA1c levels, and that was correlated to what was the possible pre-admission glycemia or the sugar level they were maintaining. And this was compared with the group, which is the current practice, where we maintain blood sugar less than 180 milligram per deciliter, and to see if this improves the outcome. So this was the hypothesis of the study. So this was a multicentric, randomized, double-blinded, parallel, randomized controlled trial, and they used sliding scale insulin protocol to achieve the glycemic control. And the primary outcome was to look at the 90-day mortality. So the background of this study is there are two landmark articles, possibly every intensive care listener would know. One was from the Vandenberg study, and one is the NICE sugar control. And before that, we had a good evidence to say high sugars in ICU, acute hyperglycemia in ICU, leads to poor clinical outcome. And these are the two reference studies which said any patient who has a high sugar levels in ICU leads to poor outcome. After this landmark study by the Belgian authors, Vandenberg et al. Came, where it showed maintaining blood sugar levels in the range of 80 to 120 leads to good outcome. So this was again debunked by Nice Sugar, which basically put a little higher level to it, saying the lesser glycemia, if you are targeting, it leads to more hypoglycemic episodes and leads to bad outcomes. And maintaining blood sugar less than 180 is good enough to have favorable outcomes. And this is the evidence that we are now sticking to as a quality benchmark. And this study was to see whether this is entirely true or should we target to basically customizing to the patient's pre-morbid glycemic control. So that's what was the study hypothesis they tried to look at. So what were the methods they used? So they looked at HbA1c. So obviously anyone who comes to ICU with diabetes, they would have had pre-admission or HbA1c levels done at some point of time. So they looked at HbA1c and they correlated to the blood sugar levels. So like 7.4% HbA1c was equated to 180 milligram per deciliter. 4.96% was equated to 111. And so they used this reference to calculate as to what would be their pre-morbid glycemic control. And 8.67 was 217. So they put the cutoff at 217 for safety reason. So they would not go beyond that. Even if their pre-morbid glycemia was more than 270, they took 270 as the upper limit. And hypoglycemia was considered if someone had blood sugar level less than 63 milligram per deciliter. So that was the sort of methods they used for this study. So in the results, they had 1,917 patients. So 942 was in the intervention where they targeted pre-admission glycemia, and the control group was 975 where they targeted less than 180. So they looked at 90-day survival. As you see, there's no difference between the targeted group versus the conventional group. And they looked at ICU length of stay. Again, here there was no difference between the interventions and the control group. And hypoglycemia occurrence was expectedly more in the intervention group as compared to the control group. Although it did not achieve statistical, but it was it was getting close there. It was 0.09. But what in the subgroup analysis, what they did, so they showed that the 90-day mortality, especially in patients who were non-diabetic, who had a high sugar, so they had a higher risk of dying. So which means to say So in non-diabetics, the intervention group where targeting glycemic control to the pre-morbid levels showed higher mortality because as you see hazard ratio is 1.3 and confidence interval is significant, and higher mortality was also seen in the post-surgical patients, and higher mortality was seen in patients where HbA1c was maintained between 5 and 6, which means to say you tend to maintain the sugars much lower, they tended to have higher mortality. So this was in subgroup analysis. So this was the striking finding they found that in non-diabetics, the risk of mortality was higher in the intervention. So the strength of this study was it was a double-blind trial in critical care because in critical care on a glycemic control, it's not easy to find many trials. So this was a good trial, which was a double-blind randomized controlled trial done in intensive care in the domain of sugar control. And the baseline characteristics were well balanced. And the protocol violation was kept minimal at less than 1%, which is also good because this is quite a complex study and a hard study to conduct. And despite that, protocol violation was kept to minimal. And all patients had a good follow-up and there was very minimal loss to follow-up. Only 9 patients had lost to follow-up. This was the study. But for all the listeners, what was extremely interesting to note in the discussion was this one. If you look at the median blood sugar level overall, intervention and control, you see the difference is only 4 milligram per deciliter. So in the intervention, although you used a complicated tools to target to the pre-morbid glycemia, the median was 135 in intervention, in control it was 139, which means there was only a difference of 4. And that's why possibly we would not see major difference in this study and it appears non-inferior. So although attempt was made to customize, but there was not a significantly huge difference between the control group and the intervention group with regards to the median blood sugar level that was maintained. And in the NICE study, so the authors talk about the strength of this study, saying in the NICE study, the control group had a higher sugars and here they maintained a much lower sugar. And in Vandenberg trial, the sugar levels are even much higher in the control group. That's why they could have found that difference. Here, since they maintained it at a lower level in control group, so one could argue that they could not appreciate a huge difference between the intervention and control group. And hypoglycemia was, if they looked at 40 to 71 as a range, 27.3% had hypoglycemia intervention group. And in the NICE study, where the criticism is because they had a high mortality in the hypoglycemia group, so 74.2% in the intervention had hypoglycemia. So they claim that here the sugars were managed much better and much more accurately, and hypoglycemia occurrence was much lesser compared to the NICE sugar study. So the limitations of this study was like to maintain a good glycemic control, there are different algorithms that one use. Here they use CPG algorithms to control hypoglycemia, to control glycemia. So the argument is, had they used different protocols, the results would have been different, is one of the argument one could raise. And here for many patients, they used point of care testing. And as we know, for such a study, one would expect to do not the point of care, but the arterial blood gas to improve the precision levels. So the precision may have impaired by using this point of care testing. And in 1,300 patients, 24% of the patients were not assessed within 96 hours after their admissions to ICU. And this may have made the study underpowered is one of the limitations of this. So these are some of the limitations pointed out in the discussion part. So all in all, the conclusion is targeting pre-admission glycemia based on HbA1c as opposed to our current practice of maintaining blood sugar less than 180 really did not show any survival benefit. So the summary conclusions that we can make is we can stick to the present standard of care, which is maintaining blood sugar less than 180, and please avoid hypoglycemia in ICU because hypoglycemia does lead to bad outcomes, which was shown in all of our previous studies. So we can continue with what we are doing. So this study possibly has no bearing with regards to change in practice. So that is the conclusion we can make. So thank you one and all.